Well, good afternoon. Thank you very much for having me. It's a great opportunity to talk about our work. I'm going to talk about kind of the classic Moya, but all the Moya-like vasculopathies that we see. I don't need to tell the audience here, Moya is characterized by progressive stenosis of the distal internal carotid arteries and the proximal ACA, MCA. In the classic version, you get that robust puff of smoke, neovascularization. Moya was first described in 1957, but the term Moya was first introduced in 1969. You get this progressive thickening of the major intracranial vessels, which leads to narrowing of the vessels. You get that beautiful puff of smoke, transmedullary neovascularization. Most of the kids will present with stroke or stroke-like symptoms. There are a lot of other entities associated with Moya, NF, cranial radiation, Down syndrome, the sickle cell, I'll just say sickle cell, the cardiac anomalies. But how do we evaluate these kids, and how do we select the treatment for them? In pediatric revascularization surgery, you typically fall into one of two camps. Either you're with the Stanford group, which advocates for direct bypass on these kids, or you're with the Harvard on the other coast, East Coast, which is the indirect bypass surgery. So I looked at the literature put out by these two groups. So Gary Steinberg in Stanford does direct bypass, and his big paper was back in 2009. And I tried to find their indications for surgery, and he indicated that they do MR imaging, cerebral perfusion studies with acetazolamide challenge and a 6-vessel angiogram, but they stated clearly in their manuscript that they did surgery only in symptomatic patients. Well, that's pretty easy. Dr. Scott, sorry, I'm going to go back. How do I go back? Okay. Dr. Scott, out in Harvard, so also almost all of his papers lack any kind of verbiage regarding the indications for surgery. There was one paper where they talked about asymptomatic patients, and they stated that it is their practice to offer surgical revascularizations in patients in whom Moya is diagnosed, including asymptomatic patients. Although they do an individual case review, they generally proceed with surgery in basically all kids that have any degree of stenosis. So that's why I think at least the folks out in Boston, should team up with Nike, because they have a very low threshold to offer revascularization for these kids. What we've been doing over about the last 9 or 10 years is to have a little bit more selective process in figuring out who is best suited for surgery and who should get medical management being aspirin therapy. In any kid that comes to us with any degree of stenosis, we typically say to the pediatrician, to the family doctor, start them on a baby aspirin. That's easy enough to do, and then we'll put them through our protocol. Our protocol includes a finely tuned kind of MR protocol that we've developed with our neuroradiology colleagues, again, over about the last decade. It's an MRI, MRA with the diffusion and flare imaging, and the key component is the ASL. We do it in all cases. It's a qualitative evaluation of the ASL. I'm sure there's a quantitative evaluation that they can do, but they do it qualitatively, and it's a 3-phase perfusion study with early, mid, and late phase imaging. And then for those kids with a significant degree of stenosis, we put them through an angiogram. And why is the angiogram so important? Well, it confirms the degree and morphology of the intracranial stenosis or occlusion. We've had a lot of kids that have stenosis, even significant stenosis, on an MRA that is overestimated. With the angiogram, you can evaluate the donor artery for bypass surgery. You can see if there's any existing transdural collaterals, either they've developed spontaneously or in response to previous surgery. And most importantly, the angiogram is a dynamic study. You can evaluate the blood flow through the various phases and identify areas of persistent or relative hypoperfusion, and if there's already collaterals developed. So this is an example of transdural collaterals. This is a kid with Moya has not had surgery, but already has transdural collaterals that you need to know about before you cut onto this kid, because if you disrupt some of those collaterals, that can result in a stroke. Some of the information that we get as we're gathering and evaluating these kids are a little more important than other pieces of information. The most important pieces of information that we feel are the current degree of stenosis, whether they're currently having any ischemic symptoms or if they've had a recent stroke, and the perfusion. Is there any at-risk brain that is currently seen with the ASL and the angiogram? It's really combining the ASL and the angiogram information that is really important. Let me just go through a few cases. So this one is an asymptomatic, no surgery case. This is an 8-year-old with a history of a craniopharyngioma, received proton beam therapy. Several years later, she developed stenosis of her distal carotid. She does have an IV sign, which in some centers is a harbinger of impending ischemia or current ischemia. So she clearly has the IV sign, but is asymptomatic, no prior strokes, no recent strokes. And her perfusion, so this is the early, mid, and late phase of the ASL. The early shows an area of hypoperfusion. It starts to get better in the mid phase, and then it's fully compensated on the late phase imaging. So this is one where we felt medical management is probably reasonable. Next case, this is an 18-year-old kid, NF1, no MCA, no prior strokes, no current strokes, no IV sign, ASL, again, hypoperfusion on the early imaging, getting better, almost fully compensated, but there's still an area of relative hypoperfusion that was confirmed with the angiogram, and so we felt this kid should get a revascularization. Case number 3, this is a 4-year-old with Down syndrome, acute right-sided weakness, so she came in with a stroke. Interestingly, no IV sign, acute stroke on the left side here. Her MRA clearly shows Moya-like changes with some of those neovascular vessels. ASL early hypoperfusion, persistent hypoperfusion even on the late images, so she should get a revascularization, which she did. This is about a year later. This shows a really nice, robust STA with all these collaterals, but she's starting to get worsening disease on the right side. So we were going to follow her because at least on her ASL, the right hemisphere is still okay. The left hemisphere, you can see on the late images, is now nicely perfused. Unfortunately, she goes in to get a catheter for renal dialysis, and she has a complication during the procedure. She has a lot of blood loss, and she strokes out most of her right hemisphere, which now is very atrophic and is now not a candidate for revascularization. Surgical management, there are a ton of ways to do revascularization surgery. In general, it's direct versus indirect. All of them work. It doesn't matter what you do, as long as you have something that has a blood flow to it, it's going to work. Some people talk about putting the omentum, tunneling it all the way up from the belly and putting it onto the brain. The French like to do the multiple burr holes. This is a direct bypass. This is where you simply invert the dura, so you make kind of a cut around one of the branches and you simply invert the dura. We typically do the peel synangiosis, which is like a modified EDAS. Basically, you just dissect a branch of the STA, typically the posterior or the parietal branch, just lay it down on the brain. And you make some openings on the arachnoid here, and then you suture the artery down. Usually works really well. You get this really robust revascularization. Oftentimes the IV sign will go away after revascularization. So here's an example. This is the images on the right here are post-bilateral revascularization. Very profound IV sign preoperatively. Now it's all gone. And this is an example, another radiation vasculopathy. She didn't have an STA, but she had a posterior auricular branch. So the, sorry, I keep pushing the wrong button. This one shows use of the occipital artery. Kid did not have an STA, so we use this occipital artery. So in conclusion, pediatric intracranial steno-occlusive cerebral vasculopathy is a very complex disease, spectrum of clinical, radiographic, and arteriographic features. Careful preoperative evaluation is key to this group of patients in trying to determine who gets surgery and who gets medical therapy. Revascularization is not needed on every patient, and the first 30 days after revascularization is the worst, okay? So that's when the stroke risk is the highest, and so you have to look beyond the 30 days. Thank you.